joining us to talk about water management. And I think it's a really interesting topic and very timely given what's going on in the pandemic and just in general. I think it's a topic of interest. So today we have with us Aaron whoop, Rosenblatt, right?
Yeah,
Um, Aaron is a co-founder of Gordon and Rosenblatt, a New York City-based consulting firm, and he advises healthcare institutions, real estate firms, insurers, and non-governmental organizations on matters that involve water and public health, with an emphasis on prevention of disease associated with water systems in buildings. He's a member of many ASHRAE.
Donna, can everybody mute their microphones other than the presenters and Donna, please?
Okay. Thanks, Joe. Aaron is a member of several ASHRAE committees. He also served on the advisory council for the CDC program development and dissemination of an online training for environmental health professionals, Legionella prevention and response. And a past trustee of the Chemists Club of New York and past chairman of the Chemists Club Library. And he has a BA from the Johns Hopkins University. David, okay, I'm going to try this, David. David Wolski. How'd I do? Not so great.
Javolsky. Yeah.
Javolsky. David is a microbiologist and received his PhD in 1980 from the University of New Hampshire in Durham. And after graduation, David worked as a postdoctoral researcher, a lecturer, a research scientist, and consultant. And then in 1994, took a position with the New York State Department of Health. And he was part of the response group for nosocomial and community-based Legionella and helped to develop the New York State regulation Part 4 and protection against Legionella. And he's currently the section chief of water systems control and analysis at the New York Department of Health. He is also serves on the faculty at the SUNY School of Public Health and is currently a research associate professor at the school. So we are delighted to have both of these gentlemen here with us, and I'm going to turn it over to them. They're going to speak for about 30 to 40 minutes, and then we'll open it up for questions from the audience. So Aaron, I think you're going to start us off, correct?
I'm going to start off, and somebody is going to put the slide up on and there we go. So thank you everybody for being here. I know that there's a lot going on in the world, even though I don't go out in the world anymore. So we're going to talk a little bit about water management plans for healthcare facilities. And most of you from your introductions probably know an awful lot about this. So we may be covering familiar territory, but hopefully we'll have a little bit of perhaps a different perspective or new information that you haven't seen before. Next slide, please. And so the water management plans we're going to talk about are primarily for the prevention of disease from plumbing associated pathogens. So today is not going to be about how to use less water or how to use less electricity in moving your water. We're going to talk primarily about prevention of disease. Next slide. So the first question you might ask is, why are we talking about water management plans in the middle of a pandemic? I've heard more than one client ask that question. Well, there are a few good reasons. Number one, next slide, please. The conditions that result from changes in water usage because of coronavirus containment measures can increase the risk of waterborne disease from building water systems. Now, in health, unlike movie theaters and airports, healthcare facilities have been pretty busy during the pandemic. So you might say, well, my overall water usage is not down, it might even be up. Why is this a problem? Well, in most of the facilities we see, even when the water usage is substantially unchanged in terms of total volume, within the facility, there may be parts where water is simply not being used. For example, in the nursing homes that we work with and the assisted living facilities, there is no use at all of the visitors' restrooms. And so we find that there are stagnant zones within the facility, even if their overall water usage hasn't changed significantly. Next slide, please. And just to go over some basics, when occupancy is reduced in all or part of a facility, the water use generally is reduced. When you stop using as much water, the age of the water, the amount of time that the water sits in the pipes increases. And increased water age has a lot of implications, none of which are good when you look at them in the context of microbial growth. And so increased water age, as we'll get into some detail later, provides conditions that are supportive of the growth of Legionella and other problematic waterborne pathogens. Next slide, please. There's also another aspect of this that a lot of people don't think about. Even if your facility uses as much water as it did before, and it uses water throughout the facility as much as ever, the water usage in communities has shifted. And so there are parts of town, like Rockefeller Center in New York, where all of Midtown has now used very significantly lower volumes of water. And so the water is sitting in the pipes, in the distribution mains and service lines, and all of the bad things that happen in buildings plumbing when the water gets old happen most of it happen in the public distribution system. And so the quality of the water that's coming into your building may be substantially degraded. It probably loses its chlorine residual. The temperatures migrate towards tepid, so the water is not as cold that you're getting in. There may be more turbidity, dirt, and sediment, and there's probably more biofilm growing in the pipes in the public distribution system than you're used to getting. So no matter what, during these pandemics, when water use shifts, you have to be mindful of the water quality, especially in a healthcare facility. Next slide, please. So talk a little bit about Legionnaire's disease. I'm guessing that most of you are pretty well familiar with it by now, but in case, Legionnaire's disease is a deadly pneumonia that can result when people inhale or aspirate Legionella bacteria that's in microscopic water droplets. You don't get Legionnaire's disease from drinking the water or from bathing in it. You get it from breathing the water. Now, in our discussions today, while we're talking primarily about Legionella and Legionnaire's disease, remember that that's just one of the organisms that cause a clinically significant amount of disease. It's a good example to work with. There's more written about it. There's more regulation on Legionnaire's disease than on some of these other problematic organisms. But you have to pay attention to them. And as we move through, we'll explain why you have to pay attention to some of these other pathogens. But for right now, we're focusing a little bit on Legionella. Next slide. So Legionella is the pathogen that causes Legionnaire's disease. It's everywhere in the natural aquatic environment. It's usually in the public water supply, and it is to a greater or lesser extent in most building water systems. Next slide. And as said a couple of minutes ago, you can get Legionnaire's disease from inhaling or aspirating contaminated water droplets. When we talk about building water systems, we're sometimes talking about the potable side, and sometimes we're talking about cooling towers. We're going to focus more on potable systems today because they're more interesting and a little more complicated. And in healthcare facilities, there's more attention to the potable than to the cooling towers. Also, cooling tower contamination is fairly easy to manage with just a little bit of attention. Potable is more complicated. Next slide. In case you don't all know this, Legionnaire's disease has been on a steady rise for about the last 20 years. There may be some difference this year because of COVID, but we're not sure how much of that is reporting and how much of that is actual decrease because of the people staying in the house. But there's been more than a 5-fold increase in the last 20 or so years. Now, there may be an exception to that for Legionnaire's disease in healthcare facilities, but that is something I'll let Dave Javolsky talk about later if he feels like it. Next slide, please. Oh, one more thing on that previous slide. The increase in other clinically significant plumbing-associated disease, infections by things like Pseudomonas and non-tuberculous mycobacteria, have pretty well tracked with the increase in Legionnaire's disease over the same time period. And Legionella is not, it doesn't cause the largest disease burden of the top half dozen or so organisms. It's somewhere, according to CDC, between number 3 and number 5. The disease burden from Pseudomonas appears to be higher. So just another reason to remember that while Legionnaire's disease gets most of the press, it's not necessarily the most important clinically of the organisms that you need to worry about. Next slide. Not going to get into the details too much of biofilm, but just we need to mention that any discussion of plumbing-associated disease needs to come back to biofilm. Biofilm is the slime that forms on any surface that's in contact with non-sterile water. Organisms attach to the pipes, they secrete a slime, other organisms can move in, and more than 99% of the pathogens in a plumbing system live in the biofilm, not in the bulk water. Also, the biofilm embedded organisms are tremendously more resistant to disinfectants than the organisms that are in the free-floating water. And so when we look at strategies for managing and sometimes decontaminating systems, we sometimes have to look at the attack that we wage on biofilm differently from the treatments that we use for the bulk water flowing through the pipes. Next slide, please. Another reminder, none of the contamination in these plumbing systems are pure laboratory cultures. Biofilm houses a complex microbial community. Many of the members aren't even identified. But of the biofilm associated organisms, there are quite a few that, like Legionella, can cause serious disease. A couple of big ones for healthcare are Acinetobacter, non-tuberculous mycobacteria, Pseudomonas, Stenotrophomonas, and so forth. So understand that this is a complex community living in. Next slide. The other thing to remember is that these are not organisms that simply occupy the same neighborhood, live next to each other, and go about their business privately. There are complex relationships between these various organisms that make them somewhat more challenging. For example, protozoa are these larger predator organisms that eat Legionella. They graze on the biofilm, they eat Legionella, they eat Pseudomonas, they eat some of the other bugs that we're worried about. In the case of Legionella and some of the others, the protozoa eat the Legionella, but they don't digest them. Most Legionella have evolved over the millennia so that they can tolerate and defy digestion. Inside the protozoa, they're protected, and they can multiply quickly to very large numbers. And then they cut the host, they kill the protozoa, and are released into the water, and then they're eaten again by other protozoa, and they keep going through the process. There are a lot of reasons that we think that protozoa play a key role in the proliferation and virulence of these various pathogens about which we worry. There's an awful lot of science there that is not necessary for this particular presentation today, because we only have about 40 minutes. But it's important to understand that there are a lot of moving parts to this. Next slide, please. We have some working assumptions that we use going in. The first working assumption that's pretty safe to make is that all of these organisms that we're worried about, these environmental source organisms, are going to get into your building water. They're going to get into the plumbing. So at least they're going to get into the plumbing sometimes, and they may be in very small numbers, even below detection limits. But assume that you're going to have them. Next slide. And we also know that the typical operating conditions of building water systems support the growth of Legionella and the other organisms that we worry about. They support the biofilm attachment and growth, and these conditions, which we'll talk about in a moment, also support the proliferation and release of these organisms into the environment. Next slide. Oh, I think did we skip one? Right. So there's another working assumption, which is that more of these pathogens with greater frequency is going to be more likely to cause disease than smaller numbers that are there less often. Here's the thing. There's no statistical correlation that anybody's been able to tease out between the Legionella numbers and disease. We do know that more Legionella and more of these other organisms is a good measure of how well your water management program is working to suppress those numbers. But we don't know with any quantitative certainty what number of Legionella in a water sample indicate that somebody is in danger or not in danger. Our friends at the CDC sometimes say that good test results don't mean that you're safe, and bad test results don't mean that you're in danger. Next slide, please. But there's another good assumption. So we have that thing we don't quite know about how to correlate the culture results with disease, but we do know that we can prevent disease if we manage the operating conditions of the building so that growth is inhibited and the survival of these organisms is challenged. And so we do sometimes do sampling to measure how well we're managing those operating conditions. When we talk about operating conditions, we're talking about simple things: temperature, the age of the water, how long has the water been sitting in the pipes, is there disinfectant in the water? So they're pretty straightforward. We'll get into some more detail there later. But just want to mention that. And also, a program that works well for Legionella will also be effective for most of these other organisms that we worry about. So when you manage the water, you're managing it for overall safety. There are some exceptions to that, and we'll mention those briefly. But in general, a good broad spectrum water management program will help prevent disease from all of these different organisms of concern. Next slide. A little bit of proof that water management programs work. CDC did a retrospective study and found that 9 of 10 outbreaks could have been prevented if they had had effective water management programs being implemented. Now, one thing that we need to point out, which may be a little bit subtle, CDC was very specific to talk about outbreaks. Outbreaks meaning more than one case in a certain period of time. The exact period of time is subject to debate, but it's typically between 6 and 12 months. CDC research did not address individual cases of Legionnaire's disease or the others. So we're really only talking about outbreaks there. We don't know if we can prevent the occasional one-off case. Now, maybe New York State Department of Health has better data on that, but most of the data is focused on outbreaks over the last number of years. Next slide. So when we talk about water management programs, we don't just sort of like to go in and be random about it. And so we found that certain proven paradigms, one in particular, hazard analysis and critical control point, work as when these methodologies are applied to managing water. This hazard analysis critical control point is the basis of most food safety programs in the world. And over the last 20, 30 years, they've increasingly been adopted for managing water, both public water supply and then building water systems. And what HACCP focuses on, I'm not going to, again, get into too much detail, but it's all about identifying the physical and chemical conditions that can support growth in a system, and then managing those physical and chemical conditions so that they're within a safe zone where the microorganisms don't proliferate. And sometimes, think of a hamburger, and how do you keep a hamburger safe? Well, you cook it, you cook it for long enough at a high enough heat so that you know that it's going to be safe and have no flavor whatsoever by the time you're finished. And so we try to do similar idea with water, control the physical and chemical conditions, and we say temporal, how long the water sits there. And we do that at every processing step, from the time the water gets into the building until the time that it's used coming out of a faucet or a shower head. And so there's really no rocket science here. It's just a lot of tedious work. And we'll talk a little bit about the tedious work as we move through. Next slide, please. So there's a standard called ASHRAE 188. Now, it was published in 2015, but it was updated in 2018. So we put the 2018 version. Actually, the picture is the 2015 version if you look closely, but the title at the top is the 2018 version. Now, I'm on this committee, and while some of the committee members don't like to use the HACCP acronym, the whole basis of ASHRAE 188, which has established a new standard of care for water management in buildings, is HACCP. It's this systematic analysis of the building water system, and then the application of control to keep those physical and chemical conditions in non-growth supportive or growth inhibitory ranges. Now, this standard applies both to potable water and also to non-potable, for example, cooling towers. It only addresses Legionella, and it doesn't address at all any of the other pathogens in building water systems. I will tell you that ASHRAE is changing that. There's another committee that Dave Javolsky and I both serve on called ASHRAE 514, and that takes this same methodology and expands it out to the other pathogens and chemical hazards associated with building water systems. But it's largely the same HACCP-based approach to managing building water safety. Now, in the case of 188, it's non-prescriptive. And so it tells you what steps to go through, but it doesn't tell you exactly what to do in each of those steps. It leaves it up to a site-specific multidisciplinary team to make those decisions. So we sometimes call this a methodological standard rather than a prescriptive standard. It does require rigorous documentation, and that's key and all the way along. We'll talk about that a little bit more later. Next slide, please. Okay, so the major steps in this water management methodology that's embodied in ASHRAE 188, first thing is to form a multidisciplinary team. Different people have different, very important knowledge and expertise and perspectives, and all of those are necessary. So the clinicians are important, the facilities people are key, infection prevention plays an important role. And something we don't always remember to talk about, it's important to have the organizational leadership represented on the team. The team has to be empowered. It has to have the authority and responsibility to develop and implement the plan. So the first thing you do, you don't start by treating anything or changing anything until you describe the building water system in detail. It's a lot like examining a patient before you prescribe any sort of treatment. Once you've got the system description, then you can do a step-by-step risk assessment. And a risk assessment has two important parts to it. One of them has nothing to do with people. It has to do with the pipes and the plumbing and the components. And you look at the conditions that would be growth supportive unless they're controlled at each step. Then you also look at the population served and the relative risk of the various populations served for getting infected. When you put those two pieces together, you can then come up with a very, very powerful risk assessment. Either one of those alone is not a complete risk assessment. So both pieces are essential. Only after you've gone through those first steps do you even begin to look at the control measures that you might apply. And for every control measure, you need to have a program for monitoring to make sure that you're applying the control as intended, and corrective actions, which are the adjustments you need to make if monitoring tells you that you're not doing what you had hoped. And again, we'll touch on those definitions a little bit more, a little further into the presentation. We then talk about validation. What do you do to find out if your program is in fact working? And how do you respond if you find out that it's not working as intended? And finally, again, we'll probably mention this more than a couple of times, everything needs to be documented at every single step. Not only is that important for compliance, but we find that when you don't document the work, somehow the work slips. And so documentation is not separate from the process. It's actually an important part of making this process work. Next slide, please. We use some defined terms of art. And so, we'll just mention when we use the word hazard, we don't use it interchangeably with a word like danger. Hazards are simply a thing. Could be a bacterium, could be water, it could be a chemical. Those things have the potential to cause harm under certain conditions. And so, those conditions are usually quantifiable. Think about scalding, for example. In scalding, the hazard is the water. The condition that makes that hazard dangerous is the temperature of that water. And so you can sort of give the same kind of thinking applies to bacteria or to other pathogens. They aren't necessarily dangerous at low levels or if they're contained, but there are other conditions where they may become quite dangerous and capable of causing harm. Next slide. And so those hazardous conditions that we've mentioned are the measurable, quantifiable physical and chemical and temporal parameters, things like temperature, or the amount of time that the water has stagnated in the pipes. Those are the things that we know can make the hazards dangerous. Now, if you go back to the hamburger, if you know how long the meat has been in transit, and the temperature at which it was transported, and the temperature of the refrigerator, and the length of time that the meat is sitting in the refrigerator, and the temperature at which it's cooked. All of those are physical, chemical, and temporal parameters that are used to make sure that a hamburger is safe to eat. At least microbially safe. I can't speak to the other health hazards of hamburgers, but so remember that that's a concept we're using here. Same concept for water. Next slide, please. Okay, so once we've identified the hazards of concern, Legionella, Pseudomonas, non-tuberculous mycobacteria, and we've got a system description, we then do a step-by-step evaluation of the system at every single phase, from the time the water comes in, might be stored, might be softened, heated, circulated, tempered. We look at every single step in the process, and we analyze for the conditions that we know, in the absence of control, could make those hazards dangerous. And what we focus on with microorganisms are the conditions that support growth. Now, another way you might think about it, your plumbing system can act as an incubator if it's at the right conditions. And it can inhibit growth or even cause the death of these pathogens if it's kept under another set of conditions. So you don't want to run your building in a way that it's going to incubate Legionella and other pathogens. Next slide. Once we've done our analysis of hazardous conditions and we've figured out what spots in the system are problematic from a temperature, water age, or other conditions, we then figure out what measures we might apply to maintain the conditions of the system in an intended safe range. An easy one, as an example, is how, when you store hot water, what temperature do you want to store it at so that you know it's not going to support microbial growth? And the standard recommendation is to store between 140 and 160 Fahrenheit, because when you store that hot, these organisms, for the most part, are not going to survive. Next slide, please. We use a lot of terms here. Sometimes people get confused, but they're still ultimately helpful. We talk about verification. In this case, verification is simply confirming that the plan that you've designed is being implemented as it was intended to be. So if you say you're going to store your water between 140 and 160, then you need to confirm that, in fact, that's what you do. If you're going to add a certain amount of chlorine to the water to maintain a level of chlorine throughout your entire system, you need to confirm that, in fact, that's what you do. And that all comes down to documenting everything. Next slide. We then talk about a concept called validation. And validation says, if you did what you intended, did it work? So after you have confirmed that the plan, in fact, was implemented as you intended, then you go and you say, did it achieve the objective? Now, if the objective is to keep the level of Legionella in samples, water samples, below a certain threshold, then you pull the water samples, you test them, and you find out if, in fact, you've manage to keep them below that level. If the objective is to keep the water coming out of the tap at 110 degrees, that's something that you can confirm. Please. Donna? Are we frozen?
No, we're good.
Okay, can we move on to the next slide? Thanks. So taking those basic principles, we go about developing a plan. Next slide. First, you need a team. Doesn't necessarily need to be a big team. In healthcare facilities, we certainly would like to have the leadership represented, somebody from facilities who knows where the pipes are, somebody from clinical services, infection prevention and control. Sometimes we like to have housekeeping on the team because they can play a critical role in implementing some of the parts of the program. And so, although it sometimes sounds trite, we say that forming the multidisciplinary team has got to be the first step. And it, in fact, is the most important step. And, even when you don't move on to the rest of the program, if you get the right people in the room around the table talking to each other, that sometimes solves an awful lot of problems before you even start the formal process of working. So we are not, we don't recommend hiring somebody to go off and develop a plan and hand it to you. You really need a team involved with the facility, with the care given, and they need to be talking to each other. Now, we usually like to get them around a table. Zoom sometimes has to work when sitting around a table is not an option. Next slide, please. As we mentioned before, describing the system is important. But the description has to have sufficient detail to enable a step-by-step analysis of the various physical and chemical conditions. So a cartoon of the system that doesn't have some of that detail is ultimately not going to be useful. Next slide, please. And there are a lot of ways to describe the system. In our practice, we like to describe the system in a number of different ways. One, to make sure we capture all the information. And also, we know that different people learn differently. Some people like drawings. And so we produce process flow diagrams that show the progress of the water from the point it comes into the building until the points where it's used and distributed. Next slide, please. We also use a lot of charts and tables to capture important information. And we also use written descriptions and annotated floor plans and riser diagrams. There's a whole host of tools. Some of it depends on, a lot depends on the complexity and the nature of the particular facility, and also on the nature of the team members that you have. Next slide, please. A little bit about the hazardous conditions. That can be overwhelming when you first think about it. And you certainly don't want to, bring somebody in to walk around and point at things and say, gee, that looks hazardous. That looks like a bad situation. In the UK, they use risk assessors who are trained to walk around and identify hazardous conditions and then throw money at them, hoping that they'll be resolved. We take a slightly different approach. And we found that while there are a lot of different things that can contribute to microbial growth, the big ones are accumulation of sediment, which for a whole lot of reasons encourages microbial growth. It's lots of surface area for biofilm. It's a thermal insulator so that the very hot water temperatures can't get to the organisms, and so forth. Temperature is key. If the water temperature is tepid, it will support microbial growth. There's an optimal range at just about body temperature, about 98.6, that Legionella and these other organisms love. The age of the water is very important. The longer the water sits in the pipes, typically the worse the problem is. And finally, residual disinfectant. Is there residual disinfectant in the water? A lack of disinfectant permits growth where a good broad spectrum disinfectant in the water, like chlorine, can inhibit microbial growth and kill a lot of the organisms. And so we made up this acronym STAR because it's easy to remember. And these are measurable, quantifiable conditions. There's no mystery here. There's no magic. We like to focus on managing things that we can measure. Next slide, please. And I don't know how many people on this call are old enough to remember the great management guru, Peter Drucker, but he used to say, you can't manage what you can't measure. And it certainly works in this case. So we focus on those things that can be measured and managed in substantially real time. And those are the things that we control. So, we're not really controlling Legionella growth, not directly. We're controlling temperatures, we're controlling disinfectant residuals, we're controlling water age, and we're controlling cleanliness. And those are the things, if managed properly, can help keep a potable water system and cooling towers in microbially safe conditions. Next slide, please. Now, sometimes when we go in to evaluate a system, we find that there are certain permanent system modifications that we might make. We don't consider these control measures because they're something you do essentially one time, and just to make the system easier to manage. So if, for example, you're on a water supply with lots of water main breaks and lots of dirt and sediment constantly being swept into the building, you might use a point of entry filter. And typically that's a permanent installation. If there are a lot of extra pipes, dead legs, pipes that were associated with a piece of equipment that might have been removed a long time ago, we'll often remove those pipes and rationalize the plumbing. Sometimes we install tempering valves after the water storage so that we can store at a very high temperature, 140 to 160, but bring the water temperature down somewhere between the heater and the time that it comes out of the tap. And another kind of modification is we'll often balance the risers. In hot water distribution, risers can easily become badly out of balance. And so while your overall flow rates might be good, you may have individual risers, risers being the vertical pipes that move water either up or down, but risers are vertical. And so those sometimes can get out of balance. And so one of the modifications we make is we come in and balance the risers if necessary. Next slide, please. Then there are control measures. And in our practice, we consider those control measures, those things which you make part of your routine operations for the long haul. So these are not short-term interventions. We usually refer to those as remediation measures. Those are very different. Control measures are the things that you make part of your normal operation. In many facilities, these things are already being done to one extent or another, but they may not be captured as part of a plan. And so we didn't put this slide in. The first things we do is we say, well, what are you already doing? So we talk about cleaning equipment, like water storage tanks, flushing the taps, or blowing down risers to remove sediment to help maintain the temperature, keep the water age down. Temperature management is usually key. How hot do you produce the water? How hot do you store the water? What is the temperature at which you distribute the water? And what is the temperature coming out of the tap to which a patient might be exposed? And as most of you probably know, there are scalding rules. So you don't, there are limitations on how hot the water can come out of a patient's tap. Other control measures, we rotate redundant components. If you have two pumps and one of them is backup, it's important to rotate the use of those so that one doesn't sit with stagnant water in the associated piping and allowed to go septic. And then finally, we sometimes use supplemental disinfection, adding a little bit of disinfectant to particularly the hot water, because hot water usually has very little disinfectant left after it's heated. Our personal choices are usually chlorine or chlorine dioxide, but there are several choices and there's a lot of considerations to be made in selecting those. But these are examples of the kind of control measures that we will routinely consider. Next slide, please. Okay. Now, for each control measure, there are different details that need to be specified. Control limits. What are the ranges? If I want to store the water hot, I don't usually tell the facility hot. I usually say 140 to 160. The more quantitative we can be, the better off we are. Monitoring is simply checking to make sure that the temperature that we've specified for control is within the range that we've specified. So if I say it's going to be 140 to 160, I have to have a means and a method and a frequency for measuring the temperature of that water at a particular spot to make sure that I'm within the range that I said I was going to be in. And then corrective actions. What do I do if monitoring tells me that I'm not where I want to be? Well, the corrective action is the procedure for restoring me, restoring those conditions back to where I want them. So if I say 140 to 160 on the hot water, and I measure it and it's 120, I take certain actions to get that temperature back up. If somebody's cranked the temperature up too high and I've got a tank full of 180 degree water, that's also not good. What do I do to bring that temperature back down into the desired range? Next slide, please. Okay. Talked a little bit about validation, confirming that the plan, when implemented as designed, achieves the objective. Now, there are various ways to do that. If your objective is to maintain water age, water temperature, water clarity, that is the opposite of turbidity, then, and you want to maintain those conditions throughout the system, then you can have a plan to make measurements to make sure that, in fact, when you apply the measures, the control measures, you're getting the result you want. So let's say I'm distributing my water at 125 degrees. Well, that wouldn't be for most healthcare facilities unless you're tempering at the tap. But let's say for the moment that I want the water to arrive just before the tap at 120. Well, I'll go around and check those temperatures and make sure that I'm heating my temperatures throughout the whole building if I've already confirmed that I'm sending the water out at the temperature that's in the plan. If I'm not getting those results, then I have to go back and figure out what's going wrong. Next slide. The other way that we validate is to take either culture or other measurements, PCR, of water samples and see what the microbial content is of those samples. Now, in New York, we do that a lot of different ways, but the main way that we do that for Legionella is to grab Legionella samples at a number of representative locations. Well, we grab water samples. We hope they're not Legionella samples, but we test samples from throughout this facility, and we see how much Legionella, if any, is in those samples, and if it's in those samples, what percentage of those samples are positive. And we have certain goals, and so we can confirm by microbial testing whether or not we're meeting our objective. Next slide. And I can't say it enough times, documentation and record keeping. If you don't have clear defensible records documenting what was done, you might as well not have done it. Now, documentation and record keeping does keep people focused on doing everything they're supposed to do. And so it really is part of the program, but also for insurance purposes, for liability purposes, for defense. If somebody sues, documentation and record keeping, of course, is vital. And of course, it's important for regulatory compliance. Didn't mean to leave that one off. In all of this practice, balancing is perhaps the greatest challenge of all. There are a lot of different things going on. And so the unintended consequences of anything you're doing must be considered. For example, if all you cared about was Legionella, you could simply circulate the water and deliver it out of the tap at 160 degrees Fahrenheit, 170 degrees. You would not have any Legionella in your system. You wouldn't have any of these other pathogens either, and you wouldn't have to worry for very long because you wouldn't have any patients surviving those water temperatures. But we don't get to do that. We have to worry about scalding. When we add chemicals to the water, we need to worry about things like corrosion products and disinfection byproducts and competing pathogens. Now, I'm going to try to be, what did somebody say the other day? I'm going to try to be tactful here. If there are some control measures, particularly when you get into the realm of disinfectants, that have some benefits, but where the the unintended consequences are far worse than the problem that we're solving. So for example, some disinfectants have really scary byproducts associated with them. Potent carcinogens that are 4 logs more carcinogenic than benzene. And in some cases, the disinfectants, while they may be effective, for example, against Legionella, may actually cause increase in the levels of some of the other pathogens of concern. And so at the very least, you want to make sure that you do no harm. And so even if Legionella is the target, and even if not all the byproducts that cause cancer are regulated right now, those things still must be considered in selecting for example, a disinfectant. So, if there's any, I guess there are 2 big messages here. If we could, 3 big messages. One is you got to know where the pipes are. 2, the STAR acronym. If you can deal with the conditions, manage the conditions represented by STAR, sediment temperature, water age, and disinfectant residual, you have a really good chance at gaining very, very sustainable microbial control. And the last thing is be careful of unintended consequences. Consider all of those things before you make a decision, because there's always more than one thing going on in any of these programs. And next slide. But God is in the detail. So there's no magic here. There's no mystery. There's a lot of tedious work, but attention to detail and being methodical will, at the end of the day, allow you to have a sustainable program. And we often say that if it's not affordable, it's not sustainable. And so with that, last slide, please. Oh, no, you can go past that one. And the next one is, I think, the last one. That's the last one.
Okay, thanks, Aaron. I know David wants to put up a checklist and talk about a couple resources available from the Department of Health in New York, and then we'll open it up for questions. So Jill, can you bring up the checklist for David to talk about, and the other 2 slides?
So while we're waiting for that,
Would you rather have the slides up or the checklist first?
checklist first, please. Thank you very much. So while we're waiting for that checklist, what Aaron's outlined, and in good detail, is basically what we would consider best management practices in the industry for building maintenance as far as opportunistic pathogens and overall water health. And don't forget, it's not just the microbes, it's also the chemical and physical environment that has to be maintained. So much of what was presented is embodied in regulations in New York State for healthcare facilities, what we call Article 28 facilities. And if it's not in the regulation, it's in guidance. And the guidance also links itself to these industry best management practices, such as ASHRAE 188. And actually, part of ASHRAE 188 is embodied in our regulation by reference, and that's regarding cooling towers, not potable water systems. But a lot of the material is very, very common to each one of the issues at hand, the best management practices versus the regulation. But if you're in New York State, it's not just good management, it's an actual requirement. So this is a checklist that covers some of the material that's required by our facilities. And the material that Aaron covered would be in these documents. Now I'm going to start at the very top. This is, does the facility have a sampling and management plan? And the sampling and management plan, SMP, is the terminology that we came up with when we were putting together the regulation. It's nothing more than a water management plan. And it describes much of what Aaron covered in his material. It does require a certain amount of detail. And we actually will look at an SMP when a facility is having a problem with a single case or multiple cases, and we'll review that. And then we actually have a three-tiered review. We have two reviewers and a final call. Basically, we go through and we have a three-point must scoring system, and we evaluate it and we say it's either sufficient or insufficient. But that happens when we have a problem with the facility and the problem is a single case or more. What you see here is a checklist that our hospital and nursing home program, and it's primarily used by our nursing home program because the hospital program is subcontracted out to another group, where they're actually checking a lot of operations, not just Legionella. And they needed a tool to say, since we've got CMS saying we have to watch this stuff, and since we have a regulation in New York State, what do we need to see for them to be good when they're being surveyed by us? And one of the things is that you have to have a sampling and management plan. And you can see the checklist, yes or no. If you have one, great. If you don't, you're going to get a citation. Likewise, there's another document about midway through, you see, does the facility have an environmental assessment form? Actually, that form would probably be filled out first. And what it does, it informs you of what elements that you really, really must have in your sampling and management plan for your particular facility. The environmental assessment form is exactly that. What are the temperatures of your water? What kind of cooling system do you have? It does cover cooling towers in a comprehensive document and goes through a lot of detail. And that environmental assessment plan is actually used during outbreaks and investigations. But again, when there is no problem, the hospital and nursing home program is looking for that sort of documentation when they do their survey. Now, if you recall from Aaron's presentation, we keep on saying documentation, documentation, documentation. And that's what this is all about. It's not just being able to put things on paper, then it is to put things into practice and then make sure that you're following what you have on paper. So again, if you don't have an environmental assessment form, or if it's out of date, you potentially can get a citation. And finally, something that we didn't really cover much in this presentation is that you need a maintenance program and plan for your cooling towers. So hospitals and nursing homes have cooling towers, and you would be subject to regulation in New York State if you had a cooling tower, and you have to have a plan for that too. We find that a lot of facilities are combining the sampling and management plan for inside water with the cooling tower, what we call outside water. It's not potable water directly, even though the tower may be supplied. And whether you have a plan or not is required, and it's required by this checklist. So what we do, we're actually approaching this from two different directions. When there's a problem and there's a case, our epidemiology group and our environmental health program, which is responsible for Part 4, the regulation, will be looking for these details. On a routine basis, when there is no problem, the nursing home program is making sure that you have all these elements. Now, they're not responsible for all the details in the program, such as the details about piping, where the risers are, what a complete temperature profile of the building. No, if they need a review of a sampling and management plan or a maintenance program and plan for cooling tower, they would submit that to us for evaluation. But you can see there's a comprehensive checklist, and that we're attacking the problem from on a routine basis and also when there's a problem. So go to the other slide, the slide deck. It's 3 slides. It won't take very, very long. This is just a bunch of links. And so for those of you who are not familiar with the regulations in New York State, these are links to elements of our regulations. This general link is to what we call Part 4. And when you go to that link, you'll see one part is related to cooling towers, and one part is related to hospitals and nursing home, what we call Article 28. Next slide. And this is just a real quick view of what the EAF looks like, the environmental assessment form on the right-hand side. And, you know, some of the elements that Aaron talked about, it's got to be updated on a regular basis. And you should be doing an assessment every year, or say, well, we didn't make many changes. If you have construction or repair activities, you have to make sure you update it. And you can go and see our EAF, the whole 13 pages of it. It's called Form 5222 on our website, and that's what the link is there for. If you want to see what this tool is, and potentially if you don't have regulations and you want to implement a preliminary assessment that can inform what might be in a water management plan, this might be a useful tool for you. Next slide, please. And finally, the sampling and management plan, or what we call a water management plan. This is where we get all the facility information, the personnel roles and responsibilities. It's that interdisciplinary group that Aaron spoke about. And it has contact information, telephone numbers, email, and who's responsible for what portion of the plan. You have to have a description of the water's building, the building's water system, and all of the control point monitoring and environmental culture sampling sites, so that whether it's pH, temperature, or Legionella, you should have those things defined. And one of the things that is required by our regulation is that if you do have a problem, you have to have a response plan for disease internally. That's usually part of infection control, but you also must contact the state when you have an issue where you're having an exceedance. And if you look at our regulation, and you could look at Appendix 4B, you can take a look at what conditions will dictate what's called an exceedance. We have a template for our sampling and management plan, and we also have instructions associated with it on our website. Maybe a useful tool for you. Many of the consultants, and Aaron is one of them, have a different approach, but the elements are the same. I mean, the order that they occur in might be different. They may have emphasis on more detail than we want for, say, our water flow diagrams. But the bottom line is we're not going to reject a consultant's water management plan because it doesn't follow our template. It's what's contained in there. And that's why we do an assessment of every sampling and management plan. And then we do a score. And we find out if it has all the elements that we require by regulation, and the ones that are also prescribed by best management practices and our guidance, and the guidance from many, many consultants. So we suggest a template. We don't require this template, but the elements are what are important. And these may be useful links for you folks to take a look at and possibly implement as tools. If you're developing a program, not necessarily a regulation, they may come in handy. And that's the regulatory part is directly linked to best management practices and all the information that Aaron had presented in his presentation. And that's it. Thank you.
Great, gentlemen. Thank you. Wow, that was very comprehensive. I don't know if you guys have any questions for them, but please feel free to ask them if you do. No, Richie, I knew you'd have to have a,
Well, I've been working on my management plan to get ready for the Joint Commission requirement that's coming up in the next, 8 months. But so my question to you, do you have control measure guideline or recommendations for in our management plan? I know you mentioned temperatures, but how about parts per million? I'm going to say in our water management plan, if we get to hit anything above anything above 0 parts per million, we're addressing it. But it as a guideline, are you specifying parts per million and temperature?
Is that for Dave or for me?
I don't know, you guys.
Dave, you want to start? And when you talk about part per million, are you talking about the CFU of Legionella? Or
Well, so it could be either, right? It could be your treatment at parts per million, and it could be your test results at parts per million, right?
It could be. So what our regulation requires, we don't address directly a residual in our regulation. That's part of guidance. The best management practices would say that you have to have a residual throughout your water distribution system, and a lot of times, and that's why we address things like water age and the residual that may be a result of that water age and temperature, that you lose residual as you go through the facility, whether it's cold water or hot water. And it's difficult to maintain a chlorine residual, for example, in hot water. So that's why temperature also becomes pretty important, because it inhibits growth and microbes from flourishing. So a lot of that falls under guidance, but when it comes to monitoring the Legionella, our regulation, we don't address absolutes. Like, we don't have a 0 recovery requirement. If you look at our appendix 4B, which is where we describe our exceedances, if you're greater than 30% positive for your sample, so if you have 10 samples taken and 4 of them were positive, you've got an exceedance. You've got to report that to your regional health department, which is state health department, and then you have to remediate that. You have to, once you do remediation, you have to pause, you have to resample, and you have to tell us when you solved your problem. We use 30% as a frequency. We don't throw the baby out with the bathwater. So everybody does CFU, but for example, if you did 20 samples in a rather large facility, and you had one site that had 1,000 CFU, is that a problem? And do you have to treat the whole facility? And in past, a lot of people would panic because they've got this one bad site. And that's exactly what it is one bad site. It's probably something unusual about that one particular location that is stagnant. It could be near a dead leg. It could be a multitude of things. So you want to assess that one site. We've done this 30% positivity for 2 decades, and it's served us well. So we know that frequency has a lot to do with it, and whether it's 1 colony forming unit or 1,000 colony forming units, a positive is a positive. But when you have that unusual situation, when your building is relatively in good shape and you have 1 or 2 sites that are problematic, you may want to look at those sites. And that's why we don't want people coming in and treating an entire building for 1 or 2 bad sites, because talk about unintended consequences. A lot of people will go in and chlorinate, and all it does is strip corrosion product off the pipe, and then you can have pinhole leaks. Another thing is that they do heat and flush, and they heat the whole system up, and they get another round of growth shortly after that, maybe a week to 10 days later. So you got to be careful about that. So you need to know your system, and that's why it's not a one-time event. It's a cycle of events. It's knowing your system. It's sampling, knowing what and where you have to sample, and getting a very, very good idea that your validation process really, really works. says you are doing what you're doing. So we do have, to kind of sum it up, we do have limits as far as Legionella is concerned. It's percent positive sample sites, but as far as what you're treating with, whether it's chlorine, chlorine dioxide, or other chemicals, we leave the treatment up to the consultants. There's a lot of guidance out there. There are a lot of consultants out there, and there are a lot of people who do water treatment. They know what they're doing. We always look over the shoulder of these folks if there's an outbreak or something like that, but we're not doing that to kind of inhibit them. We're trying to do that to make sure that we're all working together to solve a problem, because once you've hired somebody, you want what they've implemented to do everything that they said it could do. If it isn't, there's usually some unusual problem. So as far as treatment is concerned, we don't have specifications inside the building. Obviously, you need some residual in your cold water. You need residual coming into the building, and those are pretty important. And if you are treating with a particular chemical treatment, you've got to establish what you expect to see in your water distribution system, and make sure that you're actually getting the values for those sampling locations. And that would be part of your sampling and management plan, and basically what Aaron spoke about.
So thanks for the correction. I actually meant CFUs, not parts per million. So thanks for that correction. And you mentioned sites a couple of times. Do you have a site recommendation list, like incoming, distal, those type of things?
Well, we do have guidance. We don't specify in the regulation. And I'll tell you why. There's certain things that you don't want to specify in regulations, because if you need to change them, because somebody finds out something, or the literature has an abundance of information, you can't be going back and changing regulations on a yearly basis. I mean, it takes us a year just to get queued up to visit the committee that's going to consider the changes. So we would be 2 years behind before we even got things started. And we don't do regulations in public health via legislation. Okay, we have a public health and health planning committee that takes care of regulations as far as public health is concerned. So we do have recommendations of sampling sites, and usually it would be like, from the supply side of your hot water heating system, the last sampling point before it returns to that hot water system, representative sites throughout the building. A lot of times when you're going in an emergency situation, you would definitely focus on the case locations and probably the risers that fed the rooms to those case locations. But when you're not in an emergency situation, you would have to choose representative sites. And that's why you have to go through all the steps that Aaron went through. Where's my water going? What's my water temperature? Where are my vulnerable sites? Where does my residual run out? And that's going to dictate where you probably want to take your microbiological sampling. So it's not simply taking random sites. You have to know your building. You have to know where the water is flowing. You have to know your water temperature. You have to know your residual. And then you look at your weak spots, where you might have stagnant water, low chlorine levels, poor hot water temperatures, try to correct those, and then also sample those sites that are more likely vulnerable. So that all falls in guidance, but you have to they have to be representative of your building. You can't do that without doing an environmental assessment and then building a water management plan.
One thing I'll add, I'm glad that Dave left out, because this is vital, particularly in New York State. When you collect the sample set, and following guidance, it's hot water supply, hot water return, cold water entry into the building, and a minimum of 10 sites if you have less than 500 beds. And those need to be spatially distributed so you get a picture of the entire plumbing system. So it doesn't just come from patient areas. It's got to come from the other areas too. If you have a file room that used to be a laundry, you may have some awfully big pipes in there with water that sits. So you want to get this complete spatial look. But one thing that's essential is that the samples are first draw samples, the samples from these distributed sites. The whole 30% guidance about whether, an actual rule, that tells you whether you're within reasonable control or your building is out of control, is predicated on these first draw samples. If you have people running around and flushing all the taps out before they take the samples, it confounds that whole methodology. So first draw is an important piece of it. Now, because of the science reinforced by the CMS memo in 2018, we're very conscious of other pathogens besides Legionella. And so one of the things we like to do for our clients is multi-pathogen screening, particularly when you change things. So we like to know what our baseline is, and we like to know that we're not making matters worse by doing something that, for example, will shift the microbial community from Legionella and then wind up with pipes full of mycobacteria and Pseudomonas and these other pathogens that cause even more disease than Legionella, and that in some cases are a lot harder to get rid of once they've colonized. So while the state, while New York State has a fairly comprehensive guidance and legislation package, there are even more layers above that. I know that the state can't legislate best practices. They can legislate good practices based on best practices. But at least for our clients, we like to add certain layers on top of that. At the end of the day, and by the way, the extra things we do don't cost, they don't really add to the cost of the plan in any appreciable way. But we do believe that it gives us more assurance that we're not causing harm. And these days, talk about insurance. Insurance is playing a much bigger role in all of this. Part of our practice is working with insurance underwriters. And we have a client that had a few cases of Legionnaire's disease in a very large portfolio. Now, this happened to be a hotel portfolio. And their insurers paid all the claims. When it came time for renewal, they had to go to 18 different insurance companies before they could find one that was willing to write a policy for them. And the only reason they were willing to write a policy is because we were able to show them that we now had methodical, science-based programs in place which allowed them to qualify for the insurance. So, that whole world is becoming more sophisticated, and just having a plan may be good enough for CMS. Having a plan with some teeth in it is necessary if you're in New York State, and having a plan with a whole lot of teeth is becoming increasingly necessary to get insurance that doesn't have these big exclusions. So.
Okay. Other questions, comments? All right. I think, gentlemen, you've overwhelmed the audience. Mark, you have anything to add? I know Jim was the one who put us in contact with David, but
well, my comments are kind of general. Some of this is new to me. Some of this I've I've heard before, but I'm always amazed at something that's all around us that we use every day, that we drink, we take for granted, has such, if you will, complications and liabilities associated with it.
Yeah, really. It is it's like one of those things you don't want to know or think about sometimes.
Well, that's the problem. People don't want to know. And, I've worked with Aaron before, and we've had, many conversations over, nobody's got money to do the right thing when you warn them about a potential problem, but after they have an outbreak, all of a sudden, $1 million is nothing.
Yeah, right.
And Shane,
Right.
we've had that conversation too.
Indeed, we have. Indeed, we have. I was overwhelmed with the abundance of information, and I've got some questions too. When
Well, go, Shane. Go ahead.
So
Yeah.
the first thing, Aaron, thank you so much about STAR. I was not familiar with the acronym, but it makes so much sense. So does New York, Dave? New York actually require Legionella specific testing, or is the spectrum of STAR really the foundation of the monitoring, the validation of the water management program? What does that look like in New York?
Well, the regulation is named Protection Against Legionella.
Right.
It was developed in response to the outbreak that occurred in New York City. Both New York City and New York State developed concurrent regulations, and yes, it requires both subparts, subpart 4-1, which is aimed at cooling towers, and subpart 4-2, which is aimed at potable water systems in healthcare facilities, requires culture for Legionella. Now, we don't specify, and it's culture, we don't specify what species, because in New York State, we've had other species cause outbreaks and cases of pneumonia. We've had, for example, Legionella mcdadii cause an outbreak in a hospital and in a nursing home where there was a consultant involved saying, well, we did isolation of the organism and there's a lot of Legionella anisa here, but we're not seeing a problem. It's a blue-white fluorescent Legionella and they don't cause disease. We disagreed with them because the population is, if you're a microbiologist, all organisms are potential pathogens. You just have to have enough of them there and a host who's vulnerable enough to become ill. And that's exactly what happened. So we did have a case of Legionella anisa pneumonia in that particular facility. So that kind of put a couple consultants on notice and said, well, we better pay attention to the Legionella population. Another thing we're finding too, the reason why we go for the genus, of course, we know that a good majority of the time it's Legionella pneumophila 1. But we go for the genus because we've seen disease in our healthcare facilities due to other species. And the other thing is when you have a lot of these organisms, such as that nursing home that had Legionella anisa, it really confounds plate counting, and you pick representative colonies. And sometimes the colonies of anisa and pneumophila, they're going to be hard to discriminate on a crowded plate. So you might just miss it. So it's basically going to hide the offensive organism and allow all these other species to grow. So we have a tendency to be very conservative. So the regulation requires an ELAP certified laboratory that can do culture. When we look at an investigation, we're doing a screening with PCR to determine who the players are. We can find out species from PCR in 24 hours. And they can justify their culture in one laboratory, while our environmental laboratory is going to go straight to culture. We're going to culture for anybody, and then we'll speciate later on to see who the players are. And at the same time, we're hammering the physicians and infection control folks for sputum samples so that if we do get recovery from the environment, we have a clinical specimen that we can compare it to and hopefully link an exposure to a location. And we do extensive studies now are, we used to do PFGE, pulse field gel electrophoresis, but now we do whole genome sequencing because we can do an evolutionary analysis of all the offending organisms, whether they're in cooling towers and water distribution systems. And we can discriminate down to one nucleotide base in the genome. So we know how closely related they are. So yes, that's the organism of choice. Now, Aaron did say one thing, and I'm sure he's got a lot to say, is that if you have a good water management plan, you're probably going to be in fairly good shape with a lot of opportunistic pathogens. But there aren't any guarantees that you're going to solve all those problems. You got to balance your water for temperature. You got to make sure you have a residual. You have to make sure the water age is good. That if you have a problem with an older facility, that you've got a good program to move your water around. And if you treat, depending upon what you treat with, whether it's chlorine dioxide, monochloramine, copper, silver, you need to be able to know what the unintended consequences of all those treatments might be. And that's why you have to have a good water management program to see if it's working and if there are any of those unintended consequences.
Sure.
I hope
Would
I
you
answered your
say though,
question.
with CMS clearly illustrating in that memorandum summary, Legionella ... and other opportunistic pathogens, as we look at Pseudomonas, as was mentioned earlier, as being the number one, actually over Legionella, and NTM emerging as one of those public health pathogens, do you anticipate the testing regimen? Because if you're testing for Legionella and you're missing the other ones in a particular patient subset, where do you think this is going?
I can't really speak for CMS because I make a statement about all these other opportunistic pathogens, but then I think in the same memo it says you don't have to sample for them.
Right.
Okay, so
Actually, though, it's
what do we do?
sample for anything.
Right. And
CMS doesn't care about Legionella or anything else in terms of sampling. I think in part because they're worried that you can't just sample yourself out of a problem.
Right.
You have to do the work, and sampling is validation, it's not control.
And just to kind of answer your question in an indirect way, I'm not trying to avoid your question, but when we do have other opportunistic pathogen causing chronic problems, we address that particular pathogen. I worked on an outbreak of Burkholderia. We've worked on outbreaks of Pseudomonas. Where is it coming from? Can we pin it down? Is it a seasonal issue? Did somebody contaminate something? You've got storage tanks that haven't been properly serviced. All of that stuff, whether it was Legionella or not, doesn't make any difference. We were able to solve the Pseudomonas problem. The Burkholderia problem solved itself. It just went away. You keep on chasing these things, and there's the downfall. You can be really, really careful about sampling. You can have a really good plan. You could do screening with PCR. You could do culture, and you could be chasing your tail for years. So sometimes it's just make your best professional guess, treat as best as you can, keep the water moving, do what seems best for the water system's overall health. I'm sure, Aaron, I don't know if you have anything to add to that.
I basically agree. I think that, we do, what we do goes beyond what I think regulations could ever get away with. Mm-hmm. We like to test for multiple hazards. Sometimes we like to look at the community structure on a general basis. We look at families of organisms where some of the members are known to be pathogenic. Mm-hmm. Just to get a broad screen first so that we can then focus in on the areas that might be
makes sense.
Problem. But a lot depends on the nature of the facility, whether they've had a history of problems, the types of patients that they treat. And I will say that while the water testing is where in New York, the only microbial testing that's required is for Legionella
Right.
in potable water under normal circumstances. The clinicians test for a lot of things. So if they get people that are sick, they will look for a lot of the organisms like the Pseudomonas and Burkholderia and Acinetobacter and what have you. So we may then, if they find those, somebody should be telling the health department. Hopefully, sometimes they'll call us if it is waterborne. And then there's a lot of tools that we can use to chase it down. There's some, I'm not going to get off into it, but there's some really nifty things we can now do with PCR that we couldn't even do 3 years ago. And the cost of all of those things is coming way down also, which is kind of nice. So, there's a lot of tools in the toolkit. We keep learning new things every day. But at the end of the day, if you really focus on understanding the plumbing and understanding the measuring and managing the conditions that you can measure and manage in real time, the temperature, the sediment, the water age, maintaining a disinfectant residual, you can keep the system in really good shape.
Right.
And without, happy to talk to people privately about this. Not all disinfectants are the same.
That's true.
When you work with something like chlorine or chlorine dioxide, you're working with broad spectrum disinfectants that have a long history of safe use. The byproducts are well understood, and we know how to manage those. And you're looking at things that kill a whole wide range of organisms. Some of the other treatment technologies, unfortunately, we're learning select for certain pathogens, kill certain pathogens, but because they're not broad spectrum, they actually make others far bigger problem than they would otherwise be. And so you actually end up doing harm rather than good from an overall public health and risk standpoint. So, in designing the programs, you take a much broader view when you're making your decisions, and that will save you a lot of heartache. I'll tell you that usually we start with chlorine because that's the simplest, easiest, cheapest, best known. And if you can get chlorine to work, which you usually can, then you don't have to go looking for something more exotic. If you do need something more exotic under some circumstances, it's usually chlorine dioxide. And I don't know of any situations where it was necessary to look any further. So, but that's, again, a very personal view of this just based on our practice.
I think we're almost out of time, but I was going to ask if James or Kurt had any questions too before we wrap up. No? Are you, James or Kurt, either of you have any questions? No? Okay. Shane, did you have one other? We can probably take one last question, and then I think we need to wrap up.
Sure. My last question goes back to the sampling. Is I know that Canada has adopted PCR, qPCR as a first step for screening, and then culturing as sort of that second step once they identified. Gentlemen, between the two of you, what are your thoughts? Do you think the US will go and adopt that type of process where, there's sort of a 1-2 step in that premise plumbing system? I'm just curious to know what your thoughts are on that.
Well, we've been using PCR as a screening tool for a long time. So our samples go to 2 separate laboratories. One is the environmental laboratory, and the other one is our clinical laboratory. Depending upon things have changed over the decades that I've been involved with this, with the health department. But right now, the lab that does sampling from hospital potable water systems or from cooling towers is going to do a PCR screen to find out if there's Legionella pneumophila 1. Though, if there's other Legionella, they'll culture, but they know now that it may not be the pathogen of concern because a lot of the times it's Legionella pneumophila 1, especially when it comes to cooling towers. We've been testing multiple culture methods and PCR methods over the last 2.5 years. And we're hoping to be able to get a little bit more work done and maybe work with other people. But one of the methods we use is, and we tried to develop a method like this where it's PCR and it tells you that it's a viable organism or not. Okay, and so depending upon what dye you're using in conjunction with your PCR, you would know that it's positive for Legionella pneumophila and it was alive or it was not. That kind of PCR gives us a lot more information because we could start making recommendations before we leave the site.
Right.
So we have a number, we know it's viable, and we have it before we leave the site. That's pretty powerful.
Powerful.
The thing is it's right now, what we're testing is generally pretty good, but the numbers don't jive. And even the culture numbers, we're using multiple culture methods, and those numbers don't jive. The overall trend is when one is positive, the others are positive, but it's a matter of intensity. And there are certain interfering substances that we've learned that, especially when we're dealing with cooling towers or facilities that don't have good maintenance programs, that there are a lot of interfering substances. In particular, one that causes a lot of trouble with even culture, if the concentration is high enough, is iron. So, we've always used PCR as a screening tool to know where we're headed in the next few days, because the culture takes a lot of work. ISO 11731 is not a trivial method if you're doing it right, especially if you anticipate you have to test a lot of dilutions. It depends upon what your methods are for your lab. As long as you can pass, the ongoing testing for your laboratory, you should be fine. But yeah, we screen using PCR. We do culture because we're required to do culture because our regulation calls for it. So even we have to culture. And so for like cooling towers, we'll get numbers, but we're testing a lot of stuff. We're testing some new technology, and we will be changing the language of the regulation so it will be able to accommodate some of this new technology. We can't be as narrow as we were. Don't forget, this was written under emergency conditions, then it was modified. So it was written under emergency conditions in the summer of 2015 and modified by the end of 2016. It's already 4 years old. There's a lot of technology that's developed, and we've been testing it for 4 years. So, and we're still not sure. So good question. Answer is I think a lot of people are going to want to do that to save time and expedite answers, especially if you're looking at potable water systems on site. We are particularly interested in rapid methods that tell us via PCR, whatever you want to do, that I have a viable organism and I can have those numbers before I leave the site. So that's a big order. We can usually process 3 samples by the PCR method we're using before we leave the site, but we're taking 10, 12 samples at a crack. That's only a partial answer.
Wow.
Thank you so much. I appreciate that.
Yeah. Again, Aaron and David, really, thank you so much. I think we're almost at the top of the hour here, so we need to wrap up. Kim, I think for the members on the phone or on the video, I think our next meeting is scheduled for in December, the first week in December. I don't know that we've identified a topic. I was trying to remember last time we talked about something, and then